السلام عليكم ورحمة الله يعطيكم العافية. Today we will talk about the vectoral analysis of ECG and ECG interpretation, which are the last topic of the cardiac physiology. Now let's talk about the ventricular repolarization. How can we draw the vectoral axis or the vectors of the heart and on the three leads? First of all, ventricular repolarization starts at the apex of the heart. So it starts from here. We know that the general rule is that the first area to depolarize is the first area to repolarize, but it's not the case here in the ventricular repolarization. The area that starts to repolarize is in the apex and not in the first area to depolarize in the septum. Why? It is because of the blood flow. Blood flow here at this region and in the outer surfaces of the heart is better than in the inner surfaces of the heart and in the septum. Why? Because during contraction, strong contraction, the blood vessels in the inner, deeper layers of the myocardium will be constricted, so the blood flow will be minimal. But in the outer surfaces, due to the coronary vascularization of the heart, and especially in this region, it's better, so repolarization will start earlier at this region. So in the first phase of repolarization, just before repolarization, we have all the heart, as you can see here, is depolarized. Okay, so we will start from the 0 point. This is complete depolarization. And when we say depolarization, it means negative, okay, on the outside and positive from the inside. Okay, so complete depolarization means positive charges inside the muscle cells and negative charges on the outside of the cells. Okay, so this is going to be from the outer surface all negative, and we will start seeing positive charges here on the outer surface, as I said, okay, in the apex at the beginning or onset of repolarization. Okay, so here all negative outside, and here is a start of appearance of positive charges on the outside. So that's why they draw the vector, okay, here with the arrow, okay, directed toward the positive charges. Okay, there is another way to determine that, okay, which we discussed in the first lectures, to determine the direction of electrical current. So we know that from the inside of the cells, complete depolarization means positive charges from inside. So we can have here all positive charges, but from the inside of the cells. And then we will start to have negative charges again inside the cells from the apex, which are the repolarization, okay, phase. Repolarization, we know it is negative charge from inside will start to appear, which is the resting membrane potential. So here is negative charges, and the heart is going to have positive charges. Okay, so here we have from the inside positive, and this is complete, and we will start having negative, but here we still have positive, and this is again inside the cells. Okay, so the negative charges inside will be more and more until the heart is completely cardiomyocytes from inside are negatively, okay, they have negative charges. Okay, so how can we draw the vector in this case, as we learned from the previous lecture? So this is still depolarized, the last part. Okay, so here we have a current of negative charges that is going through this direction. Okay, so negative charges are moving toward the negative, or positive toward the negative part. Okay, if we say this is positive here and this is negative, so negative charges are moving toward negative. And from the rules we talked about in the first lecture, negative charges are going to the negative charges. That means a positive, what? A positive vector or axis of the cardiac axis. So this is from the rules that we learned in the first lectures. But if you use the rule that have been used in the book, they always refer to the surface charges, not to the inside of the cell, as we talked before. Please make sure not to be confused when you return to your textbook. They refer to the charges as surface charges. Okay, and for surface charges is exactly the opposite. The case is opposite. For surface or outside the cells, the depolarized heart is going to be negative, completely negative from outside, and then positive will start to appear at the apex, and they always draw the vector of the heart with the arrowhead on the positive charges. So this is the way that your book is using. Either ways, it will give you the same direction of vector, okay, which is downward and to the left, okay, toward the positive. So let's go back to the vectoral analysis. Okay, so this is the vector. We just move the vector as is. Okay, and as you can see here, the vector is here. Okay, then we draw perpendicular line to the first lead, and then the second lead, and then the third lead. All of the deflections are going to be in the positive. Why? Because the projected vectors are all here in the positive in the positive sides of the axis, of the first axis, first lead, second lead, and third lead. Okay, so we will start having a positive deflection all through the steps of repolarization phase. Of course, we will reach a maximum, and then the line or the axis vector of the heart will be shorter, because most areas are going to be repolarized until we reach a point where all the areas of the ventricles repolarize. So we return to the isoelectric line, which is this. This is the isoelectric line, where there is no current, because the heart is either completely depolarized or completely repolarized. The case here, after the T wave, we have complete repolarization. Okay, we are back to the resting membrane potential. So this is a summary of what we have already talked about. How can we draw the vector and the projected vectors in the leads, and the direction of the vector of repolarization, ventricular repolarization. So we talked about the QRS complex and how can we make the vectoral analysis for the QRS complex on the 3 leads. And now let's go back and look at the atrial depolarization and atrial repolarization. And we know that atrial depolarization has a P wave on the ECG. Actually, atrial repolarization we don't see, and we said before, we explained that we said that it happens during the QRS complex, so it is masked by the QRS complex. So atrial depolarization starts at the sinus node, as we discussed earlier, and then spreads toward the AV node. Okay, so atrial depolarization starts just at the opening or to the superior superior vena cava, where the SA node is there, and then spreads, okay, all the way downward and to the left side of the atrium in this direction, as depicted here in the red arrow. This is the vector, okay, the main vector, the instantaneous vector of the atrial depolarization. Okay, so because it's heading toward the positive, or it is along with the cardiac vector, it's going to be actually a positive vector in lead 1, 2, and 3, and it will give a positive deflection, and that is the P wave. Okay, now how about repolarization of the atrium? We know we cannot see that, but what if we can see the atrial repolarization? How would it be drawn? So, as we said, after complete depolarization, the heart, okay, the atrium of the heart in both atrii, we're going to have a negative charge from the inside of the cell or outside of the cell. It's going to be a positive inside and a negative outside. Okay, so at the end of atrial depolarization, we will have positive inside cells and negative outside cells. Let's take the inside of the cells, because this is the easier for us, because we know depolarization and repolarization with regard to the events inside cells. So after depolarization, the atrii, okay, all will be depolarized and will have positive charges all the way through the atrii. Now, repolarization will start in the first areas, okay, first areas that depolarized. So it is actually with the rule. It is with the rule. Okay, it is along the rule. So the first area to depolarize was close to the SA node. So here we will have the start of seeing the negative charges inside to appear again from here. Negative charges. Let me draw the negative charges here. Okay, that will start to appear, but we had positive charges, okay, from the depolarization, okay, here. So the negative charges will start to move in this direction. So negative charge is going toward the positive side. Okay, so this is a positive side or positive electrode. It's going toward the positive. So negative is moving toward the positive. So it's not moving toward the negative electrodes. So that means the vector is going to be negative and not positive. If the negative were going toward negative, that will be a positive vector. But because negative charges are going to the opposite direction, to the positive, it's going to be a negative vector and it's going to be a negative deflection. So if it was seen, it's going to give us a negative repolarization wave in lead 1, 2, and 3. Okay, if we used the rule of the book, the charges will be exactly opposite. In the book, they refer to surface charges. Okay, the charges will be opposite, but the final vector is going to give us the same direction of the vector. Okay, it's only another way to see it or to determine it. So for surface charges, they have in depolarization, okay, in depolarization, they have on the surface negative, and for repolarization, on the surface, they have positive. So those are in the surface, which are exactly the opposite from the inside. So complete depolarized heart will give negative charges at depolarization on the surface and positive charges of repolarization on the surface will start to appear from up to down. Okay, so that means the vector head which points toward the positive will be in this direction, and this is exactly what we got from the first way. Okay, so it is going in the direction of negative direction of the axial reference system. So it's going to be a negative deflection in all the three leads. I hope that this is clear. If you have further questions, we can go ahead and explain that to you again in the live session. One of the main things that we can learn from an ECG record or a cardiograph is to measure the heart rate. We can measure the distance between the R's, or we can take the RR interval, the distance between two R waves. So we measure this time point or time lapse between R and R. So if it was 0.83 seconds, for example, then we convert the seconds or the minutes to seconds in order to get how many beats per minute. So for each beat, it lasts, the one beat lasts 0.83 seconds. So we convert the minutes into seconds in order to get how many beat per minute. Okay, so this is beat per minute. Okay, 72 beat per minute, and this is the normal heart rate. So again, let's remind you with the intervals and segments that we can get from the ECG. This is the RR interval. So we measure this distance by counting the small squares. Then by counting the small squares, we can know the time interval between R and R in seconds. So if it was 0.8 second, then we can know the heart rate. Okay. And again, this is the calibration of the ECG that is standardized. Okay, as you can see here, we have these small squares which are 0.04 second, and the largest or the larger or big squares are 0.2 seconds. We can also determine regularity in the ECG waves. So if we can see that the RR interval is exactly fixed, okay, the same time between R's of the ECG, so this is regular. Okay, so we can use markings on a pen and then measure these distances. So if they are regular and equally apart, then this is regular rhythm of the heart. If the intervals were not equal, so this is irregular, and even irregular can be regular irregular or irregular irregular. So this is how can we determine the regularity of the rhythm, to know what are the diseases that could happen in the rhythm of the heart. Now, we can also make use of the ECG deflection waves and the segments to detect some abnormalities in the cardiac or in the heart, okay, or in the cardiac rhythm. So again, let's remind you with the SA node that will generate the electrical activity of the heart and will be transmitted into the whole atrium and also into the AV node, where there will be a small delay of the electrical current, and then it will move to the AV bundle, okay, and Purkinje system toward the ventricles of the heart. So the sinoatrial node is the pacemaker, the normal pacemaker. It will decide the heart rate. Okay, so the atrial depolarization is represented on the ECG wave by the P wave, as we know. And we have actually the QRS complex, which represents the ventricular depolarization, which happens after a while of the atrial depolarization. Okay, and then we have the ventricular depolarization wave, the QRS complex, and then we have ventricular repolarization. Okay, meanwhile, or through the time during QRS complex, we have atrial repolarization that we don't see on the ECG, and then we have T wave, which represents the ventricular repolarization. This is just a reminder for you. We are already familiar with these informations. Okay, the intervals, we have the PQ interval, okay, and as you can see here, it's about 0.2 seconds. 0.2 seconds. So from the P wave, which is atrial depolarization, to the start of ventricular depolarization, which is Q, this is the PQ interval, which is 0.2. Then we have the QT interval. This is also a very important interval. So from the beginning of the ventricular depolarization until the end of the ventricular repolarization wave, this is the QT interval, which is also very important to know, which is about 0.4 seconds. Now, if we had the PQ interval is longer, if PQ interval, we found that PQ interval was longer than 0.2 second. So if this was longer than normal, so this will be a first degree heart block. So that means there is something wrong with the conduction between the atrium and the ventricle if this is longer than 0.2, like PQ. Okay, and this is what we call first degree heart block, a problem in the conduction between the atrium, the SA node, and the ventricle. Now, if there was an enlarged QRS, if the QRS was very large, okay, so the depolarization, the voltage is actually magnified, okay, as you can see here in this picture. Okay, this is a huge QRS, larger than what we expect in the amplitude of the voltage. That means there is hypertrophy of the ventricles. So that's why the voltage of depolarization waves, the amplitude is high, okay? Because the vector of the heart is higher, and that is depicted here in the very long R amplitude or QRS complex. If we see a prolonged QT interval, so if it was longer, the QT was longer than normal, okay? See, this is the normal QT, about 0.4, and here is extended. So from the time of beginning of depolarization to the end of repolarization is long, it's taking long time. So that means there is repolarization abnormalities. So the repolarization is taking longer time to happen. And when repolarization takes long time to occur, this will cause arrhythmias. Okay, this will increase chances of ventricular arrhythmias. Okay, when repolarization is abnormal, it takes longer time, okay, to occur. So that will give chances to other excitable nodal tissues or parts of the conductive system to start making electrical or generate electrical potential that will make irregularities in the rhythm. Now, what about the elevated T wave? If T wave, this is normal, okay, and this is, okay, elevated T wave. So the T wave is actually more, the amplitude is more, it is elevated above the isoelectric line than normal, okay? So it is elevated. So this is normal, and this is higher than it should be. So what does that mean? Or this is due to which abnormalities in the heart? It's actually indication of electrolytes imbalance, which is the hyperkalemia. So it is indicative of hyperkalemia. What about a flat T wave? So it is closer to the isoelectric line. Okay, it is actually indication of the opposite, hypokalemia, or sometimes ischemia. Okay, so the previous abnormalities are the most common abnormalities that we want you to be familiar with in this course. So to summarize, the findings that we can see from ECG: anatomical orientation of the heart by determining the cardiac axis, Then this we can know if there is hypertrophy in some sides or some parts of the heart or not. Also, we can determine the relative sizes of the chambers, some of the disturbances of rhythm by calculating the heart rate, and the conduction, if there is any abnormality in the conduction due to ischemia. We can figure out that by the intervals that we talked about. Also, the effect of electrolyte abnormalities, also by the knowing the intervals from the ECG, and some of the influence of some drugs that you can know more about in the pharmacology